this is an open mic session. We heard some experts speak with their presentations earlier. I want to hear from people responded online, but I just want to hear people speaking about what's on their mind, their experiences. I am going to go through the slides we have, but we all have mics in front of us, and I want to hear what's on people's minds. So, survey methodology. Anna asked if I could introduce her to my survey team. The survey team was me uploading her paper and Olga's paper into AI and asking it to create a survey.
Really?
Yeah.
Ouch.
What? Yeah, I already. Yeah, that's my team. I don't know what she thinks we have going on in the background here. That's all it was. Nothing sophisticated. So yeah, so it did a great job. These were the papers that interest me. It didn't hit on subjects that certain people put in the comments, particular to our state, like malpractice, but it did hit on everything in your articles. So we had a total of 110 responses. Our society does have a lot of trainees, a lot of people that aren't practicing radiologists. So I was happy with this. Just to show you the demographics, I'll go through this stuff quicker, but the largest percent is people in practice greater than 30 years, and then after that, it's 20 to 30 years. Primary setting, academic, follow at 51.4%. Then we have private practice, and then we drop off after there, the hospital employee, and then it gets a lot smaller after there. And that could be that these members aren't part of our society, not interested in filling out surveys, haven't really to dive into that. Obviously, most people are from New York. Majority are primary clinical, so greater than 70% of the time is clinical, 72.2%. And of the respondents, great majority are diagnostic radiology only, 76.1%. That was followed by both diagnostic and interventional radiologists at 15.6%, falls off after that. So work, how many hours do you work a week? So most people, the biggest response was 41 to 50 hours, then was 51 to 60 hours, getting up there. It looks like we have people that go over 70 hours a week. I don't know if anyone has any comments here. I can move along. Okay, please read your agreement with the following statements. 1, blue, strongly disagree. 5, strongly agree. My current workload is sustainable. I have adequate time to provide quality interpretations. I regularly work above my optimal capacity. Any comments? So this might be more of a review of results than an open mic, but please, if anyone has anything to say, chime in. It is a little scary that a lot of people don't find. Please. Yeah, push a button, it should turn green.
Thank you. It did turn green. All right. Because nobody was speaking and I'm always the loudest person in the room, I'm just going to comment on, can you go to the previous slide if you could? So Benson me kindly shared the data, and Peter, that's why I was a little late with my presentation, because I saw an Excel spreadsheet and I could not resist it. And what I did was I looked at the differences. I sorted everybody by academic and private practice. And what I've noticed was that there was absolutely no difference. And so private practice, literally in the hours worked, the same distribution was identical to academic practice. And what it made me personally made me think that, knowing that the difference in vacation times, is that I personally am going to talk to my chairman and say, is it worth it, perhaps for flexibility purposes, to actually offer the new hires and the present radiologists more vacation rather than raises. And then, as Olga pointed out, the internal moonlighting, which exists, and people perhaps could then vary what kind of compensation they wanted in money or time. So that was my thought. I haven't shared it with you, Ben. I have lots of thoughts. I'll share them.
I'm looking forward to it. Agreement with following statements. Just I have sufficient time for non-interpretive tasks. Seems like a lot of strongly disagrees to not a lot of ones and twos. So that seems to be something affecting us. Staffing of my radiologists in my practice is adequate, as we know, we talked about before. That doesn't really seem to be the trend. Like I said, everyone's hiring. If anyone has any comments at any point, please just raise your hand or start speaking to the mic. My vacation time is adequate. When Anna was saying how much time private practice radiologists have off, I think Justin sitting next to me was not familiar with. Maybe you don't get that much in law. No, okay. Yes. Yes. So compensation is adequate. Widespread. Okay, so how concerned are you about the following issues? I think we've hit on the workforce shortage. It seems this is really on everyone's minds. But to say again, we're all hiring. Declining reimbursements. Don't think we touched so much on that. If anyone has any comments, and the amount of administrative slash bureaucratic tasks. Someone has to have something to say about that.
Well, I'll have something to say about the declining
Okay,
reimbursements,
thank you.
which is something that's, one of the big issues has been Medicare. And a lot of things, a lot of our reimbursement is tied to Medicare and Medicare rates. And so fixing Medicare is a priority throughout the House of Medicine, and has been the top priority for our American Medical Association. And this year when we lobby on Capitol Hill with the ACR, that will be our top priority. And we stand with the House of Medicine trying to get this fixed, not just because of the reimbursement issue itself and us getting paid, although that's important and very important, particularly with our trainees having high loans and life just particularly in New York being expensive. But it also is a problem for our seniors who won't have access to Medicare if people aren't taking it because the reimbursements are too low. And so again, I think we need to prioritize that. And I think the House of Medicine is, our ACR is, and when the House of Medicine speaks with one voice as they are here, it's particularly effective. And so we hope that we can get a permanent fix for this, one that allows us to see cost of living increases as the other sectors in healthcare get.
Great.
Because it's open mic, may I ask a provocative question? And we will provoke conversation, I promise. As I was preparing this talk, I was consulting with my colleague, and his wife happens to be about our age, a geriatrician who took care of, I think half the elderly population of New Jersey. And we were talking about reimbursement and how and earning, et cetera, and the question was literally, I was sorting through the data, and I said, a lot of people feel that they're not being reimbursed enough. She said, Anna, why do radiologists think that they're not reimbursed enough when, we in general medicine are not reimbursed half as enough as you are? And so the issue really that we are in this group, we're all radiologists, and I also want to earn a lot of money, and I want my trainees to be able to pay loans, but our clinical colleagues are paying the same rents and the same college tuitions and the same everything, and they're not being reimbursed, right? And they're working very long hours. And so when, we're talking about this, are we are we starting to exceed, like in our reimbursements, in our incomes, are we starting to exceed what, society wants to pay us? I mean, that's a question. Have anybody is worried about that?
So you had talked in your talk about cycles and how we had seen them, and we have seen cycles with that as well. Particularly going back to like the 1990s, where we had seen reimbursements that hit a significant high, and then there was a correction there, and the reimbursements went down and salaries went down for radiologists. So I think when you're talking about that, there are going to be these ebbs and flows and market corrections. And I don't know that I can predict the future with what is coming with the changes in our government and funding for healthcare and all of that. So I don't know what's going to happen with that. But again, when I talked about speaking with one voice, it's the declining overall physician reimbursement that's the problem. As I see it, what ends up happening, and you hit it right dead on, is that the problem has been that there is one healthcare pot for physicians. That pot keeps shrinking, and then they keep asking us to pit one specialty against another and say that yours is more value than ours. And we need to speak as one voice and say, what physicians do is important. It deserves to be compensated. And we are not going to be there anymore saying that, you're going to put the physician, the radiologist against the geriatrician, because we need geriatricians, we need radiologists, we need everybody to be adequately compensated.
And thanks for all your advocacy work, Abani, with all this.
Just to kind of support your claim, when I was reading about anesthesia, their claim is really that their reimbursement also decreasing, and they quote exactly the same numbers that compared to what they were earning, 20 years ago, their reimbursement went down, if I remember correctly, about 20% down. And that's one of the drivers why they have CRNAs, right? They're cheaper. Not that cheap, but still cheaper, right? So I think it's the common thing, and I this is amazing that you're getting everybody together as one voice for medicine.
And I mean, I think this one slide to me is the real reason why we have to listen to our speakers today and really become more efficient and start adopting tools such as AI to really, because remember, reimbursement per study is not salary, right? It's not what you're earning. Even if reimbursements go down but you're able to read more and do more work, then what you take home or what the practice takes home will be the same. Workforce shortage, same thing. If there's not enough radiologists, we have to get more efficient at what we do and how we do it so we don't burn out. So I think this one slide here is sort of the exclamation point on that we really do need to embrace new technologies and new ways of thinking about things to move to get to the future where we remain viable.
Thank you, Dr. Hentel. For the benefit of the folks who are online, who can't see you, just announce who you are when you start speaking.
That's my brother. Any other comments here?
More of a question rather than a comment. One of the things that we all do, especially in academic center, but I see it more and more in private practices too, is multidisciplinary tumor boards, which are increasing in numbers. They just we went from like 5 maybe a decade ago to just so many, and it's there's already data how many work hours it takes. Anybody, and this is Olga Brook, sorry. Are you guys being reimbursed, supported in any way? No way. No. Okay. And so one of the strategies to be supported is basically, if it's outside study, is to have second reads, to require second reads, but that just adding more volume to your endless work list anyway.
Is anyone being reimbursed for that work? No one? And is multiplying everywhere? Pulmonary nodule conference, this conference, that conference. And they take a lot of prep, longer than they used to.
Unfunded mandates.
Yeah. Okay. It's a lot of time. I know how important it is, but it's a lot of prep time, and it's a lot of, yeah.
But one thing I will say that I think they've been doing right over at Northwell is with the second reads. They've been putting that into your RVU calculation. So I think at least it makes you feel better when you've read those studies that it's not just like unrecognized work that you're doing. And I think that's important that they know that somebody is recognizing you're spending a piece of your time on doing these outside reads.
This is, you're talking for tumor board or breast consults in?
I'm talking about it's things like, preparing for surgery. So wire lokes, things like that, is being counted in your RVUs. And that was a recent change that was made, and I think actually helps morale and
that's
is
great.
a good addition.
It's probably harder to read outside studies where you don't know the ultrasound text and you don't know their imaging. So yeah, that's great. Okay, we're concerned about imaging volume. We're concerned about increasing complexity cases. And we're concerned about corporate private equity acquisition of practices. That's one thing we haven't really touched upon. It seems like most of our, a very small percentage of our respondents are from Hey, please announce yourself in case no one's familiar.
Anna Rosenstein. I am personally quite concerned about private equity acquisition of practices because this is the group which is most concerned about income rather than quality. And I would predict that they will be implementing AI first. And I would also predict that they're most likely to implement it indiscriminately with less attention to performance. So I am personally concerned about that.
Going back to Dr. Murov, I think he would say to us that when we think about private equity, we should not think of them as they, we should think of them as us, because the decisions to sell practices to private equity are largely made by us as radiologists. Those are business decisions. It's not my role to question them, but what I would say is that we have an obligation as a profession to our trainees as they're looking for jobs, even though jobs are plentiful, to make sure that when they go into those jobs, they're given the accurate information on pending or prospective sales, and that they are not tied to restrictive covenants that mean that they, if the job doesn't work out, that they then can't go and find somewhere else to work.
Here.
Mark Adams. I want to give maybe just a slightly different spin on this private equity. Maybe it's not just the private equity, maybe it's the level of competition and the oligopolies that have been established out there. I look at that much like the insurance companies. There's one, two, three insurance companies in the area. They have market power. This is what's happening with the private equity firms. Perhaps being a capitalist at heart, perhaps breaking them up into smaller groups, creating some competition like we want to do with the insurance companies is another way to look at the problem.
At our board meeting last night, when I was talking about what was on my mind, the radiologists in hospitals in my neck of the woods are pulling out for reasons like not being reimbursed for all the work they do, and they're going to their outpatient offices, and then these corporate private equity companies are coming in, and the reads are, again, you get paid per read, and the quality's not there. I read an impression that I came across. I don't know what the heck they were talking about. Okay, competition from non-physician practitioners, integration of artificial intelligence. Anything here?
Yes. Mark Adams. At the last, the one on the right there, the concern about integration of artificial intelligence. I don't know, maybe we ought to be more concerned about that, but I agree with trying to incorporate it. Otherwise, Star Trek, we could be replaced by it. So we really need to incorporate it as quickly as possible.
I actually, Bonnie Lidvack, sorry, I actually looked at that a little bit differently. Like first I was like, oh, wait, people aren't like really thinking about it. But actually, I think the fact that the middle bar is the highest is actually probably good, that the majority actually are thinking of it. And we're getting past that early adapter phase and into the phase where we are going to have general uptake and interest in it. So I actually think that follows that like normal cycle of how people adapt to things. But I do find it interesting looking at that. In terms of the competition from non-physician providers, we talked about that, a little bit before, but I don't really look at it as a competition thing. I look at it as a safety and a quality thing mostly. And the key here to me is that we practice in teams because we know that teams are the safest, and that these independent practice things are silos, which is not actually helpful to patients, and actually sometimes can be very harmful. And so I think the key here isn't about competition, it's about teams.
Well put. Okay, I'm going the wrong way. Okay, so what percentage of your work is performed remotely? So majority, 43.1% said 1 to 25% of the time. And then there's a good chunk, almost a quarter, 0% of the time. I thought post-COVID that a lot that there would be less than 20. I thought more, less than 25% would be fully on site, but I guess that's where we are. Any comments here? Okay. Level of burnout. So professional burnout, that seems pretty high. Emotional exhaustion, that seems pretty high. Impact on personal life, not as high, but still pretty high. I think these are things that were discussed in our presentations before. I think I think we're all aware of it. Yeah. Anyone have any comments here?
Just Bonnie Litvak again. I think that we really, this is a really important slide. We need to do better in this space. Radiology has been one of the fields that has had higher physician demoralization and burnout. And maybe it's something that we can actually talk with at our ACR, maybe even in open mic session at the ACR on, what we can do. We had a talk at our last Women Physicians Leadership Academy from the American College of Physicians, who started a program, a wellness program nationally and they have wellness ambassadors, and they've had check-ins, and they've actually seen significant improvement with that and engagement with that. And it might be something that we can think of doing on a national level for radiology, or even some of it on a statewide level where we can partner with MISNI on ways to get at that. The American Medical Association has a very big program on Steps Forward, and it talks about what institutions can do, because a lot of our burnout factors have to do with systemic factors and not our individual personal factors. And so we can learn some lessons there and partner with them. The AMA actually has been giving out awards to institutions that have made improvements. And if your facility or system is not involved with the AMA in those programs, that might be also another opportunity for them to learn what's being done nationally to make some improvements. And most of these organizations like to be recognized for things, so getting an award from the AMA is actually a positive for the institution, and it helps the physicians that are there.
Nice.
This is Doug Mintz. I just have a question about burnout, and I really don't know the answer, and think there are some people here who might. Do we know how much of this is based on individual characters and how much is based on the environment? So you take somebody who's predisposed, then there's less environment involved. Somebody who's quite resilient, then there's they're more protected. Is there work on the balance there? I just don't know.
Please, someone who knows about any of this.
So actually, it turns out the physicians, when they look at a scale on how resilient people are based on professions, physicians actually are at the top of that list in terms of their resilience ability. And so it is actually something that is concerning when physicians who are extremely resilient are having these levels of burnout. And that's why the AMA got involved with the program to the extent that they're doing it in their steps forward, was because we've got very resilient physicians. So it wasn't the resilience of the individual physicians that was the issue. It was the systemic factors that are there. A lot of it having to do with things like EMR, in our case, our PAC systems, and excess paperwork, prior authorization, and all those administrative things that are actually causing a large majority of the burnout. A lot of it is what's eating into our pajama time and taking us away from our families. That is adding to this. So while there are things that we can do, and physicians are doing those, and those are their personal factors, the personal factors are about 10%, 90% are the systemic factors.
Yeah. May I add to this? I don't know of any data comparing resilience of radiologists to other specialties, but we are a very different specialty. Anna Rosenstein. Okay. And we are an isolated specialty. We very frequently now, particularly with remote work, are socially isolated, particularly when we don't come to work and don't have a team, et cetera, et cetera. So I would be concerned that whereas that we may be somewhat less resilient, because not all of us have families for our pajama times, if you know what I mean, right? And if we, that we may see ourselves more and more burnt out compared to other specialties because we have no human contact frequently.
Hi. So, yeah, Anna, it's Elizabeth Malton speaking. As a remote worker, I can tell you that for most of my career, I did work on site, and then becoming remote required different strategies to combat that sort of isolating feeling. And it can be done, but you have to recognize, what the differences are and what's impacting you. Make sure you get sunlight, get up and walk around. Make sure you have interactions. And one of the things that's really made a difference for me personally is staying involved in organized radiology, going to the LIRS meetings and coming here and being involved in the ACR and staying engaged in my profession, even if my daily reading responsibilities have changed. The office setting has changed. When I first started in this practice, we had common reading rooms. And if you wanted an opinion on something, you called to the person across the room, hey, come and take a look at this. You can still get second opinions, but you call somebody up through your internal system and they log on to the case. And it's very different. So you need to come up with different strategies for changing times. But yes, it's an isolating thing. Even if I still went in, it would still be an isolating event. I don't do procedures. So I'd be sitting in a room, reading cases on site. And I think you have to sort of be conscious of these things as you work, what's affecting you and come up with strategies. So I think it's something we can talk about. And I think it's great to talk about it in person. I mean, I appreciate that we're all online together and that there are some of us that are spread out. But it's nice to see faces, and that actually makes a big difference for me personally. So I just wanted to share that.
Thank you, Elizabeth. Okay, so here's what some questions about what's contributing to burnout from our members, right? Daily case volume workload, complex cases without adequate time, after hours on-call coverage. So yeah, it seems like these volumes that we keep talking about, right? They're insurmountable. And yeah, as a body imager, I do find things getting increasingly complex. And yeah, yeah, it's difficult, and when you have 1,000 other things to do, you got that case where you can really make a difference in patient care, and it's hard to carve out that time and give it what it needs. Anyone have anything to say here?
In addition, at least in my experience, we just having added need to get patients out of the hospital. I work in a hospital setting, and so there's an enormous pressure as our patients are getting more and more complex because they're surviving longer and longer. Surgical techniques are getting better, right? We also now have a push for much quicker, report because we need to get them out of the hospital. So that's time pressure is also there.
One mitigation strategy that works personally for me is teaching, right? When you feel completely burned out and you're tired and, the list is long, I take 3 cases from my collection and take like residents, come on over. I have a few cases to show. And that just reinvigorates me and helps everyone. And it's a strategy.
Maybe that's why academics are not quite as burned out as private practice.
I'm just, as we're talking, we go through the rest of the factors contributing to just show the graphs: administrative/bureaucratic loss of autonomy and practice decisions, inadequate compensation for non-interpretive work, which I think we were hitting on, poor work-life balance, corporate/private equity influence, declining reimbursement, technology-related frustrations, and inadequate staff support. So if we want to talk about any of these things or none of these things.
On behalf of someone who had to leave the meeting but is chiming in online, Gian wanted me to also mention, in terms of burnout, exercise. Get up, get out of your chair, do something. So.
Thank you.
Mark Adams. I was just looking at this slide and the one in the middle, loss of autonomy and practice decisions. I think that leads to apathy. The fact that most of us are employed now and we really have very little decision rights. And that apathy, I would think that would maybe, sort of erode into our resilience and allow for increased burnout and dissatisfaction. I don't know what can be done about that. I think Bonnie touched on it earlier. If you look at the big picture of reimbursement, because reimbursements have gone down, not specific to just radiology, but physicians in general, they have not been able to keep their practices open. And that's why we've gone from 70% of private practice physicians to 75%, approaching 80% employed. And with that is loss of autonomy, a loss of decision rights. And a lot of us went into medicine because we like to make decisions.
Sorry, to respond to that about loss of autonomy, I think it's a kind of fitting itself. A lot of people don't want to make decisions, don't want to get involved, then getting there, and then they're less involved in the practice. What I see, and I see it more in a younger generation, is that if they want to be involved, they want titles first. And so sometimes you have to start doing the work and start to be involved and start to volunteer and do things. And you need to take that autonomy. You need to take that work, and then titles will come with that. But I think it's fitting to get itself, this process. And loss of autonomy is, some of it is because we're employed, but I think in any practice, employed, not employed, private activity, not private activity, they're looking for leaders. And this leadership needs to come from the ground up. And starting to work from that is helpful. And this realization needs to come to all of us, that we can make a difference. We have our opinions, we have our thoughts, and we can make a difference. It doesn't matter the titles.
I just wanted to add, Anna Rosenstein, that data show that in the animal kingdom, a leader is defined as such individual which moves first, and that is bees, birds, and everybody else. So Olga, I totally agree. Okay, our trainees have to move first.
So I see that, but you sometimes have to push them. I mean, for the trainees, and if you're the leader, I don't know that the trainees have the responsibility for moving first. I find it fascinating that you can take somebody who's kind of not necessarily a great resident or not very enthusiastic, and then you give them a bunch of responsibility, and they rise to that. They rise to that occasion.
Thank you so very much. Rubaya will nod now. I do that all the time.
This is Ritesh Patel. So just to echo on that, I think, I'm one of a junior attending, and I was a resident not too long ago at the same practice that I joined now at Northwell Health. And I think a big proponent is I think there's a lot of residents or young individuals that have a lot of interests, but first it comes down to what the culture is in your department or in the system. I think it's helpful when there's competing targets. You have to have productivity, but then you have your interest and you have to pick which one's more important. When you have a culture that facilitates like, hey, this is an important task. If you have interest in it, here's a task to do. And this is how we would kind of balance that. That's very helpful. And I think it's a great model to build on the culture first and then to, work together as a team.
Yeah, some of that's harder to measure than RVUs, right? It's yeah. Anyone else?
Hi, this is Rubaya. I'm one of the radiology residents. I guess adding on to that, I think also trainees are changing over time. I think someone had mentioned earlier that maybe it's that trainees are less resilient now than they were previously. I think it's also that trainees have to jump through more hoops now to become a trainee. Like I graduated medical school in 2022, and I was one of the youngest people in my class just for going straight through. I was one of 5 people who went straight through like college to medical school, but the average age for the starting medical student was 26. So that's 4 years of gap years. Like, so I think people are already coming in more burnt out. In addition to our economy has changed, we can no longer afford housing. Like someone who's in their 30s still can't buy a house. COVID happened. So I think times have changed since before. But I do think like it was mentioned before, the culture matters. So being around all of you people who are very interested and passionate about the field, who have, who care, I think that really like can reinvigorate trainees to see that, okay, like all hope is not lost. We can actually make a difference in things that we do, whether we're given titles or not given titles. I think events like this are really important for us.
That's great to hear. And yeah, with all the workloads and all the burnout, I think people who inspire you, my job has the same problems as every, but I'm really happy to be in the trenches with the folks I'm with. It makes all the difference. Gonna have to battle.
Sorry, this is Ritesh again. Something in line with that, I guess, for those of you that are kind of involved in like medical schools and, radiology interest groups and so forth. I think, recent the AI boom, there's a lot of content out there on social media that's, radiology is the first to be replaced and so forth. How is that stigma like existed or, kind of, how do you see that currently in like the medical school? Because we're looking to increase residency spots, but if we have people that are not interested in, how do we tackle that and move forward with that?
Anna Rosenstein, I think I may have to answer this. I'm back. Association of Program Directors in Radiology, of which I'm a member since 2005, runs its matching plan committee, basically runs data forecasting, et cetera, et cetera. I was I started forecasting, literally predicting the future. We've been pretty successful. You know, it's hard to predict things, especially regarding the future, but we try. And so this is happening right now. It looks like our incomes are at the peak, and so we should see enormous boiling interests from medical students. We have seen small shrinking in the applicant pool last year, not 2024-25, 23-24, and significantly more shrinking this year. Last year, I shrugged it off as self-selection because it was really hard to get in. This year, I'm very concerned that we are seeing the beginning. We're seeing the beginning of self-driving cars in San Francisco, understanding that, you know, things are going that way. We have just expanded the number of positions by 50, which is about 4% increase over 1 year. This is just one woman's prediction. I will issue an advisory in October of 2025. Watch out, I'll put it on Twitter. All right. I will look at the pool and I will basically forecast. Now, we are much better off right now than we were in 2021. Our pool is now the same level of 2021, and our number of positions is much higher, right? And we are at the same level of not matching. It means that signaling works, all right? We're doing better. But I think that you're right, and that we are seeing the results of AI-induced panic. Right? We have lots of excellent candidates. We have DOs. We have IMGs. A little bit of data, a very large study, which I promised in Pennsylvania in 2009, amongst 3 years data from the CMS, all right, looked at the entire state and the entire physician corps. The best mortality and morbidity and shortest lengths of stay was in non-citizen IMGs. So people who were not citizens, who were IMGs trained somewhere else, had the lowest mortality and morbidity in the units. We American grads, citizens American grads, had a 7% higher mortality and longer length of stay. The Jackie, data on request, I have it's all in my laptop. I'll share it today as needed. All right. The non-citizens, the citizens IMGs. So this is American citizens who went to medical school somewhere else, the Caribbean, had the highest mortality and the longest stay in the units by 16% greater than non-citizen IMGs. All right. So we have enormous talent, which is right now being actively discriminated against. The problem that next year that I'm seeing, I'm going to tone this down, is in our ability to extend visas to the new talent. And that is a huge problem, which we as a society will not be able to solve, but might be able to work for as citizens.
Just to build on that, so our IMGs, but also there's, we talked about culture and perception, and I think that that's very important. I think our ACR has been there trying to guide us through the AI changeover and guide us into the next phase for radiology, and just looking at it. And when people have asked me, from other spectrums, aren't you concerned about radiology's future? And I've said no, because when MRI was coming into play, people said, and it first called it NMR, and they said it stood for no more radiologists. And then a few years later, it stands for actually now more radiologists. And that has been radiology's course over time, has been, we are adapters. We are a technology-based field, and we learn how to adapt to technology. And there's always people, again, that are are, against it, are slow adopters. We have the early adopters, and then we have people that just go into where the mainstream is. But our ACR is leading the way on that, and not hiding underneath, some sort of a rock, and showing us the way forward on AI. Our institutions are starting to use AI. We're getting the data on it, and we're going to do what radiology does, which is use our data and move forward so that we actually look at what's using AI, as both of you said, for what makes us more efficient and what makes us safer, and provides more quality and better outcomes for our patients.
So just, one more comment about medical students not going to radiology because of the AI panic. If you think about it a little bit more, primary care is at much more danger of AI than radiology, right? Most of what they do can be replaced by ChatGPT today and would be probably better off, more compassionate, more, spending more time and giving better answers, right? Like somebody has to do physical exam, sure, but otherwise, probably better than that APP. So AI is going to be part of everything that we do. We just have to do it right. We had one scare of AI for medical students. We now understand. The best example is the self-driving cars. It's always 5 years away, right? It's still 5 years away, right?
Not in San Francisco.
And believe me, all radiologists in San Francisco are still driving their own cars, right? Right. So yes, it exists. Yes, there are pockets. Yes, it's great for the long drivers, etc. And the same will be in radiology. It will be working for certain things, but it's not going to uniformly, as we all know.
The real question is the time frame. If our panic amongst medical students happens now in the next couple of years, and if our AI adoption takes longer, we are in deep trouble. However, if AI panic can be mitigated and adoption can be streamlined and sped so that we work with AI, not AI works without us, then we're going to be much better off. It depends.
So we have a couple of medical students here, and they love being put on the spot. It's just something I know about medical students. What do you guys think?
Hi, good morning, everyone. Third year from downstate. My name is Kwok. Yes, I do love being put on the spot. Finishing third year being pimped by all of my attendings throughout the year has been an excellent learning experience for me. I am speaking sarcastically. But yes, as someone who's been interested in radiology for some time, from the beginning of medical school, I think I've been faced with the question of AI, and I've been, in some cases, actively discouraged from pursuing the field from other residents in other fields that I've spoken to recently. Like I asked, and I say, "Oh, what do you want to do?" I'll say radiology. They're like, "Are you afraid about AI? You really should think about not doing it. Are you afraid of being replaced?" I feel like these are kind of questions that I've heard a lot. These are questions that I've heard from my upperclassmen who have successfully matched this year, and those who I've spoken to in previous years. It's something that weighs on our minds. I feel like I've spoken to many people who are currently practicing in the field, and much like they're not, I mean, I think we saw the survey results there as well. They're not extremely concerned about the fact that they will be replacing us, but rather augmenting the nature of the work that you do. So at least from my perspective, I'm not particularly concerned, and I think that that's an opinion that I'm trying to share amongst many of my colleagues. But certainly, I'll say that right now it's still very heterogeneous. There's no general consensus amongst the medical students. I guess the data cannot lie that application numbers are lower, but I think at the same time you see that other people who are still very interested in the fascination of what the integration of what this field has with technology and the unique circumstance that it has with how it affects the work that you do. I think that still will remain one of the biggest draws for the field as a whole.
Thank you. That was great. There's one more.
Hi, everyone. My name's Emily. I'm a first year, so, take my opinion with a lot of salt. But I guess most recently, like as I've been thinking about specialty choices, I have been talking with like other physicians, and this is just like one anecdote, but even like more recently, a urologist was talking with me, like my sister's friend, and her first opinion was immediately like, no, like don't go into radiology, like AI is totally going to take over. And this is from someone who is like very highly educated, went to UNC, went to Stanford, and like my first reaction was not to take to take that with a lot of grain of salt, because it's someone who's practicing in a different specialty and might not have the insights that you guys have and have like discussed today. But I guess it is kind of discouraging because that kind of perhaps like misinformation is even with other specialties who like maybe don't work so closely, or don't have like the everyday experience. I think the other thing is maybe part of the panic is that even as medical students, we don't really have the insights about AI, or it's not really integrated into our curriculum. So you only kind of get your information from like whether you like have mentors who are able to do that, or if you go online, where of course like online is like always the most negative takes on any issue. So yeah, I guess I'm not really quite sure even where I would get like really good information.
Here, right.
Yes, I agree. I think today was really encouraging, I think, for sure. But I don't know where else I would have like directed someone, or like if I like hadn't gone today, like I still would have had those maybe misconceptions or even hesitations about coming to a field.
Thank you very much.
Hello, everyone. My name is Ketan, one of the PGY4 resident at SUNY Upstate. A question with the speakers. They mentioned how much I agree that the conclusion is adopting with AI is the better way forward. The question is, how do we go about it in terms of where do we start and how much is too much with adoption with AI?
How much car is enough? How much adopting a car rather than a horse and a buggy is enough? How much infrastructure do we need to put in terms of superhighways? And how do different societies choose to go into railroads, into the car? The answers are, a lot of it is path dependency and so on and so forth. There's no single one answer. But to go granularly right now, basically, there are only two options, right? You either introduce a platform, and one of the most common ones right now is, for example, AI Doc. I use it. I happen to be familiar with it. There are many other excellent programs, right? Or there's a large language model, and it's not either or. Both need to be there, all right? So every single institution, in my view, in order to improve functioning, efficiency, quality, et cetera, should really form a group of interested and knowledgeable people who are going to use available data and lots of reviews, right, to see it's bang per buck, right? I mean, these things cost money, but in my view, they're worth it.
It's honestly, to me, it's very disappointing that we have such disparity, right? Because anytime you see a lot of options, that means that there is no a clear winner. Seems like AI Doc winning, but still, there is just still too many options. And the answer is, what is too much? The answer is pretty clear in any organization. It's ROI. It's a business plan. Like when you're trying to introduce something, you need to know what's your return on investment, how much it's going to improve the life and workflow and efficiency and the throughput, and how much you're investing. That's what you're weighing in. That's when you buy a new car versus old car. That's the same strategies. I don't, what it's going to do. And a lot of those solutions are reprioritizations and things like that, or faster detection of pulmonary emboli. Well, if you're already reading PEs pretty promptly, you probably don't need that solution, right? So it's a matter of what solution for what purpose. And yeah, the same thing about self-driving cars. It's 5 years away. It continues to be 5 years away.
Hi, Nolan Figetsu. Full disclosure, I'm on the CSC, so whatever ACR apologist, I suppose. The ACR's position is that radiologists who use AI will replace radiologists who don't use AI, and I use AI every day, so hopefully I won't be replaced. And I think for my advice to residents is or students is to go to a program that uses AI, so you learn about it, and that not all programs use AI every day. We use clinical AI every day. I don't necessarily know what goes on at the back end. And then showing my age, how much is enough? MTV, remember MTV? Too much is never enough. Thank you.
So we are running short on time, and obviously I appreciate everyone showing up early, and it's been almost 4 hours, and I really appreciate. There are a good number of more slides, but I think anyone who registered online, I did send out the survey results, so you can just click on them, discuss them with your friends and family. One thing I did want to find. So how optimistic are you about the future of radiology? So it seems that although we're all burnt out, we all have too much work, but I think we remain overall optimistic. No? And that's good to see, because we need to forge on during these tough times. I do have there's many committees in our society who do a lot of great work and make the society run. Often at the end of the meetings, we have them give reports. Today, I think we're going to forego that for the sake of time. I will try and distribute that information by email and put it on our website. And anyone have any other comments about the open mic session before we call it a day? I just want to thank everyone again. Our speakers were fantastic. Congrats, Dr. Bello, Dr. Adams, and thank you everyone for showing up.